Hello and welcome to this video with Albie and I guess. Albie's joining. He was scratching at the door when I was trying to record. So I'm going to try and have Albie on my lap while we do this one. Here's another video of a psychiatric interview from the 50s with a patient who supposedly has a hebephrenic schizophrenia. Now, hebephrenia or hebephrenic schizophrenia is not a term that's used anymore. It was used in the 50s, 60s, 70s, and it kind of represented the more disorganized thought form, odd, bizarre thought form. Based on that, I might expect that the person has bizarre delusions, illogical thought patterns, and kind of nonsensical thought flow. So one subject not following from another. This teaching resource and that psychiatrist in these videos is really good. I've seen a couple of his interviews and he gives lots of space for the patient to speak, asks nice open-ended questions, and usually makes for really fascinating content. So I'm quite excited actually to watch this one. I've got a lot of videos about schizophrenia, so if you want to learn more about the illness itself, please check them out. I won't spend too much time talking about it right now. There's lots of videos you can watch online. I'll go straight to the reaction. But before we get into it, if you're new here, a warm welcome. My name is Dr Syl. I'm a junior doctor from Australia, and I make educational and reaction mental health videos in my free time. I do these videos in a personal capacity. I'm not representing a college, a workplace, or a institution, and all advice here is general in nature. There's no personalized medical advice in these videos. Other than that, let's get into the video.
I
can't hear you, Joe. Can you speak a little louder?
Hey?
You got that job?
Yeah, I look for a job somewhere, I don't know.
I look for a job somewhere, I don't know. That's what he said.
Yes, sir, yes it is.
See this?
That's the boy, it's me there.
You
That's
hold
me.
it? Look at it. That's you?
That's me in San Antonio?
That's you, huh?
Yeah, it's me. Oh, yeah, and Dorchester. Is that in Dorchester?
No?
Oh, yeah, yeah.
Why are you sitting in that way?
I don't know.
Why are you sitting that way?
Well, this is the boy sick.
Were you sick then?
He's not sick, he's heart attack. See, he has a blood pressure. See? Yeah.
So the microphone's very soft and his voice is very soft. I've been able to make out what he's saying a little bit with these headphones. I guess the first thing to say is he's a little dysarthric in how he speaks, and that can be for many, many reasons, but it's not uncommon that if people are on high dose of first-generation antipsychotics, which might be the case in the 1950s, that they could experience what are called extrapyramidal side effects like dystonia. What does that all mean? Well, the old school drugs that actually some of them are still used today, but a lot of the drugs that they used in the 50s caused side effects of involuntary muscle spasms, and sometimes they would have the tongue would dart to the side of the mouth and the flip like this, and that's called dysarthria. So they're dysarthric speech, so they wouldn't speak well. So I'm not sure why he's speaking like that, and it certainly can be many reasons. It could be dentition, his teeth. It could be part of his mental illness. It could just be his personality. I don't know anything about him, but anyway, I just thought I'd bring that up because it's relevant for the context of the time. The photo was particularly informative. It was someone in an odd posture. Any ideas to the medical students watching what that would be? Yeah, it's called catatonia. So catatonia can happen for many, many reasons, not just schizophrenia. And I think actually the majority of catatonia is not in psychotic illness. It's mostly in affective illness, but it can be from it can be from medical conditions as well. And so there's lots of different symptoms in catatonia, but one of them is called abnormal posturing, where people's muscles, the actual tone of the muscle itself, is slightly rigid. So it's like it causes it's a waxy flexibility. So you move it and it moves, but it's kind of hard to move, and then it holds in position. And so I've seen patients, and there's footage on YouTube of patients as well, and in these odd positions, and they can last for hours in these positions, right? It's an actual issue in the neurotransmitters in the brain and how that relates to the tone of the muscle. And they can just hold these positions for hours. Now, catatonia is a life-threatening emergency, right? It needs to be addressed immediately. You have to go straight to hospital if someone's catatonic, because people don't eat, people don't take care of themselves, and you can also get muscle breakdown as well. Also, being immobile comes with heaps of other risks, right? You can get pressure ulcers, you can get clots in your legs. It's got very effective treatments as well. So I guess we're piecing together a bit that he's had a catatonic episode, he's come into hospital, they've treated him, he's gotten a bit better. And by that, I just mean he's not catatonic anymore. At the start, it was a bit hard to make out what he was saying. Anyway, let's keep watching and see if we can make sense of his thought form, which may not make sense.
No, sick. You're always in the city, you're always in the quarter. Is that better?
He's what?
Does out in the city. Yes, money, see, this. Does out in the streets. Water, the show, and beer. Yes,
This boy goes to shows, he drinks
smoke a
beer.
cigarette, smoke a pipe. Does that
Well, and you?
Well, this man, that's the boy, huh? That's the boy. Yeah, yeah. So many years you go on the streets, downtown, you see, he has a job, he makes money, that's it.
Well,
You have no job, you stay home, sit home, you
who's the boy?
Huh?
Who's that boy, Joe?
Old that boy is? 35 years old.
Who is that boy? 25 years old. So I guess I'm getting the sense that there's quite significant thought disorder. Now, thought disorder is when your stream of thoughts don't make logical sense. It can be subtle. It can be like loosening of associations, or a bit tangential, where one thought loosely links to another, but then, if you're asked a question, you might never really get to the question. It can be circumstantial, where you get asked a question and then you just talk around the answer, and you never really, well, you do eventually get to the answer, but you just talk about so much detail that doesn't feel relevant to the answer. That's another type of thought disorder that you see in psychosis. And it can be night's move thinking, where you kind of answer a related question, but not quite. So, can you tell me about your dad? And then you start talking about your uncle or something. Anyway, here there was pretty loose. This was kind of night's move-ish, kind of loosening of associations, where it's, who is this? And then he tells the age of this. So he's not quite answering the question. I also noticed maybe a bit of an accent. I'm not sure. It's kind of hard to work out the audio here, but you got to take that into consideration. And if someone has English as a second language, you've got to do this with an interpreter. But that could also explain not understanding a question could obviously influence your your answer to that question, of course. But this person seems to be slightly thought disordered so far. I guess it's really important that we remember this is all speculation, and we keep an open mind. And in psychiatry, when you work in psychiatry, it's all about formulating, and formulations are always changing. So it's a hypothesis, and you're always formulating the hypothesis. Yeah.
Is it you?
Yes, man, you buy a soul, you buy a hat, see, you go on the street. Is that it? This boy has a job, he smoke, go on the street. Does everything.
It's odd that he doesn't recognize himself in the photo. In schizophrenia, there are lots of misidentification kind of syndromes. So someone with schizophrenia may look at someone he knows or she knows and fundamentally believe that that is an impersonator of the person. It can't be that. It's not their brother. It's an actor playing as their brother. This can be quite risky, especially if there's, risk of violence and things. So you have to take that into account in the risk formulating and the risk planning and the risk management. So there's also the other way around, where you see a complete stranger and you feel you absolutely know them, like they're someone you've known your whole life, or they're your parent or something. And that can be problematic in terms of risks of stalking and things like that. There's others as well, but not recognizing your own photo of you is, really getting to a point of the self being fully dissolved. One way to think about psychosis is that it's an issue in the boundaries of the self. So I know that this body I have is me, and that this pen on the table is not me, right? That's my boundary of the self. So to the best of my knowledge, I am not psychotic. I can see this clear boundary. Someone in a psychosis, they might see a pen on a table and somehow that pen is related to their self. They might think it's a device monitoring their thoughts. They might think it's an implanted decoy. They might think it's a grenade. And when I say think, I mean believe in an emotional and intense level with reasoning that would feel illogical because it's not based in logic. It's based in mental illness. And they don't realize the pen is a separate entity that's unrelated to the self. Now, that's the kind of essence of paranoia, right? Paranoia is thinking that things that aren't related to you are related to you. And it's all about ego boundaries, or the boundaries of the self.
And now you're in this place.
Huh?
You're in this place.
Sure, on this place. As long as I have a job, I come here. See?
How long have you been here?
I've been here about 900 years.
How long?
900 years old, this place. He built up
I couldn't get it. How old? How long?
Huh?
How long have you been here?
Been here? 900 years.
900 years?
Yeah.
That's
I
a
built
very
this
long
place.
time.
Sure.
Couldn't
He
have
built up
been
my
here.
yard, he built up his place. He buy chocolate, cigarettes. I pay, huh? That's the story. When I have a job, we go on the sea. He does everything. Yes. He's Oxford them, man. He's everything.
So yeah, I think English isn't his first language. Maybe Italian accent, I'm not sure. But he's smoking, and that's really interesting. Like nowadays, you'd never see this, right? And anyone who's been an inpatient or has worked on inpatient units knows how challenging the rules are around cigarettes because first of all, if someone has a mental illness, there's increased rates of smoking. If someone has schizophrenia, the rates of smoking are very high. It's one of the ways of coping with stress is to smoke. It's not the most helpful way, right? There's huge risks with smoking. It's one of the most unhealthy things someone can do. But when do you think is the worst possible time to try and quit smoking? When you're having a psychotic relapse of an illness like schizophrenia. It's so, like, it just adds a whole other element of stress. And I'm not saying whether there should or should not be smoking on mental health wards. I'm just noting the pros and cons of it. And the cons are that it definitely increases agitation and probably risks to staff and from the agitation because people aren't allowed to smoke. So if you can imagine someone who's a pack-a-day smoker, who's psychotic, who then needs to get admitted to hospital involuntarily and then isn't allowed to smoke, that's their way of coping. They're getting medicines they don't want. It's an extremely traumatic experience, and then they have to go into nicotine withdrawals. Very, very difficult experience for those people. We do what we can, patches, gums, lozenges, but I can hear you smokers watching, screaming at me saying that crap doesn't work. Look, the evidence actually does show that it does work to reduce objective kind of markers of agitation and withdrawals, but it doesn't seem to do much subjectively. So people don't feel it works, but it does seem to make them less agitated on objective measures. So yeah, I realize why health systems don't allow smoking on the wards. Makes total sense, but there are costs to it, and that just needs to be acknowledged, I guess.
Drive a car, you go on the street. He does everything.
Who drives the car, Joe?
Huh?
Who drives the car?
I can't hear you.
Who drives the car?
Car, you, anybody. I don't know. I go on the streets, downtown, uptown. He's everywhere.
But you're in the hospital now.
Yeah, he does
Are you sick?
Sick. Sometimes I'm sick. Blood pressure, heart attack, the eyes. Sick. I broke a finger. See, I press, I go basic. He's everywhere. Drink lots of beer, go to the show.
What do you think of Montreal?
Montreal tramway. Montreal, yeah.
What about the Montreal tramway?
This is Montreal tramway.
So that was an interesting kind of... Anyway, I'm sure they're about to talk about that kind of thought stream because he's like, what do you think about Montreal? And he answers tramway. So interesting jump there. Hard to follow. But he's kind of fatuous in some of his beliefs, right? He's saying he's 900 years old really casually. He's saying he has heart attack, problems with his eyes, problem with his breathing, really casually. So, yeah, that's just worth noting.
This is Montreal Tramway?
This is Montreal. Yeah?
Oh, this is not the Montreal Tramway?
Huh?
This is not the Montreal Tramway.
Is that Montreal Tramway?
No.
What is it? American City?
What is it?
Or sanitarium? Sanitarium?
It's not a sanitarium. What is this?
This is a boy around the streets. Is everything. Is that?
It's a boy around the streets.
Boy does everything. Sick. He's everything.
He's sick. Are you sick, Joe?
Sick in the blood.
You're sick in the blood. How do you feel?
Oh, sick in the winter. Oh, in the summer.
How do you feel?
How I feel today? Oh, he's all right as I am. Take out his teeth. Take out his... It's a young boy, eh?
That's a young boy, yes.
Oh, yeah, it's a young boy.
How old are you?
Huh?
How old are you?
25 years old.
How old is this boy? Well, he's about 20.
Oh, it's a man. Oh, it's a young boy, eh? She's that man.
What would you like to do now? What would you like to do now, Joe?
Hmm?
What would you like to do now?
Now? Oh, I don't know. We're on the streets. Is that
Go around the streets?
she got the money?
Would you like...
So there's just a period there where he it's hard to really know, but it could have just been he couldn't hear the interviewer, but he seemed preoccupied with his internal experiences. And it's always worth noting in these interviews if someone is responding to unseen stimuli and if they're being preoccupied with internal experiences, because some people who have had psychosis really describe that reality is the dream and what's happening in the mind is reality. And so when you are trying to talk to them, like this examiner was trying to talk to him, he's in a different reality. He's having his own perceptions, experiences, beliefs about, experience. And it's very, very different to the objective reality that he's in. And then the examiner kind of has to break through that. He has to ask multiple times, and it almost shocked him out of it. And that shock response is quite typical of someone who's in a kind of distracted psychotic state, because they might be hearing these or engaging in dialogue, subjectively they might feel it's like telepathic communication. They're engaging, and then your voice is kind of blurry to them. There's so much sensation. Your voice is kind of blurry, and it just pops them. You have to kind of break through the experience they're having to pop them out, and it causes a bit of a shock sometimes. So that was an interesting observation.
Would you like a Coke?
Sure, sure.
Well, let's see.
What's our Coke?
Mm-hmm.
I'm in.
For you, yeah.
Okay.
Wow.
Well,
Full disclosure, I've never gotten any patient a Coke.
It's all right, man.
He's all right, my man. Is that what he said? That's nice.
What's my that?
Okay, 3 weeks
tell me
later.
what it is.
Sitting?
Yes.
Oh, this down the street.
It's what?
Streetcar is it?
A streetcar.
Yeah.
Where's the streetcar?
Streetcar downtown, Ontario, and every street.
Oh, I see.
What is it then?
What did you tell me about your heart?
Huh?
How's your heart?
My heart is all right.
Your heart
There's
is
a
all
heart
right.
attack. There's a... This is a man. He's a butler.
And you work all over the world?
Yes, I work.
Where do you work?
I work in the factory.
So important to acknowledge. So if someone with a psychotic illness is describing somatic complaints like a heart attack, you got to take it seriously. You've got to do the investigations and investigate it. It's kind of like chest pain being from psychosis or anxiety is a diagnosis of exclusion. You have to exclude the life-threatening things first. It can often be, there's often somatic misinterpretations. So they might say, instead of my chest hurts, they might say, oh, I can feel kind of the radio waves tickling my chest, or that, there's an implanted device here. And so they might have a kind of psychotic this explanation for a real somatic experience, a real bodily experience, like pain or like odd pins and needles or something like that. So taking a history you might have to be a bit more creative in how you hear someone's symptoms described.
15 years, I think.
Did you work in England?
50 city all over the world.
It's quite an odd facial expression he's got. So his affect is kind of grimacing in a way. I would like to ask him why that is, but not exactly sure.
For the world?
No,
How do you get there?
Huh?
How do you get there?
I get it with my 4 feet.
On your 4 feet?
First, and as I think,
You have only 2 feet, Joe?
oh, it's safe first. Take a streetcar and then go to work. Then you go home, take a streetcar.
How much money do you have?
How much
Joe?
money I make? $100 a week.
100 a week?
Yeah.
But you're in the hospital, you know?
That's a lot of money back then. So that could be related to a grandiose delusion as well. He seems to be kind of, I don't know if flippant's the right word. These aren't, his beliefs are rapidly changing, and they're very changeable, and he's kind of casual. And a classic delusion is intense and front of mind and all encompassing and preoccupying, and you can't stop talking about it. I can't stop talking about the fact that I make £100 a week. I don't know what that would be equivalent to these days. If he's making $100 a week in the 50s, that must be like, I don't know, let's call it $100,000 a week these days. So, when it's a classical, like a classic delusion is really held with intensity and yeah, it's front of mind. It takes up time. Whereas his kind of thoughts, they kind of feel like confabulation. They're just kind of changeable and jumping around a lot, but not reality based as well. So it's a bit interesting.
Yeah, in the hospital, he's sick. He's everything.
What about the arrested?
Arrested?
Yeah.
I was arrested. I got us, I punched our Zager. I catch $1 piece of paper.
What's that?
$1, is it? What's $1 piece of paper? $1 piece.
What about the mounted police?
You want the police? $1 picture face?
Who's the mounted police?
A man who went to see a park in mountains. Monterey City, I don't know.
And the provincial
You're a
police?
provincial. You're a provincial?
No, I'm not a provincial.
Just a note of interview technique. This is my style. I always like to keep my eyes at the level of the patient. So this kind of looking up to a psychiatrist, maybe they've got a rapport and an alliance therapeutically that they can do that. But I think best practice is keep your eyes at the same level as the patient. And that's also a safety thing. So if a patient gets up, I get up, right? I don't let a patient stand over me. And so if they get up, I get up. If they sit down, I sit down. And you just try and stay at their eye level. Standing over a patient can be very intimidating. And like if a patient's in a hospital bed and you're standing over them, and they've had previous trauma or previous bad experiences, there's a huge power dynamic there. It's best to just try and stay at the same eye level as a patient. So that's just an interview note that I thought I'd add.
No, I don't want the police.
You're the mounted police?
Policeman from Dorchester, in the hospital.
You're the provincial police?
Yeah. I catch $1 piece of paper.
You catch $1 on a piece of paper?
One many friends. I catched a man, he got me arrested. That boy, we got some money. She finished. I catch $1 piece of paper, fish tank.
You're a provincial policeman?
Yeah.
And what am I doing?
You're a mounted police.
I'm the mounted police?
Yeah, that's a mounted policeman. Yeah.
Well, I'm a doctor. I'm a doctor, Joe.
Huh?
I'm a doctor.
Oh, you're a doctor? A police is a doctor? A dentist?
Well, a policeman isn't a dentist.
Sure. What's a policeman? Is it regular?
What's a policeman doing?
Policeman is a dentist. That's everything the same.
Policeman is a dentist.
Sure, is that. I move all the parts of the world.
What is that?
I learned from the hospital.
All parts over the world?
Yeah. That's me.
That's you?
Oh, yeah.
What's you?
All the parts of the city.
What's you, Joe?
Huh?
What is you?
What I do? My name is work office in Copenhagen.
All over the world?
Yeah.
What are you doing?
So you can imagine after seeing someone like this gentleman leaving the room and just saying, what did we just talk about? What just happened? That's the importance of when you're documenting getting quotes, because this is thought disorder, and it's also misidentification. So he is thinking that that he's a police officer, that he's acting as someone he's not, and it's got grandiosity to his thought form, and yeah, to his beliefs, and so this is looking to be it's hard to call it treatment-resistant schizophrenia at this point because it's only 3 weeks later and it's the 50s. I don't know what his treatments have been, but it's definitely still florid psychosis. And I wonder if there's other elements with the confabulations, if there's an alcohol use or an intellectual disability as well. There could be other components here. There's clearly a forensic risk. He was talking about the arrest with the police, so that would be really important to know more about as well.
Just what are you doing? You were going to tell me what Sitsi was.
What Sitsi? Sitsi is a stinker.
What do you mean?
Stinker, the work off stinker in hand.
Show me the picture that you have.
Picture, right over here. This is how to do.
What do you mean?
What you say? What's my name? What's in the lane? So boy, I was a millionaire. You know me? He was came out, man, after you know this man? That man's a bootlegger. You don't know? I said, this man's an Americaner. I'm American citizen in England. Yes. 1900 years. Sit down, man. Oh, you build a well. Oh, I see you build a well. Oh, I bet. What's together? Oh, get a mason. You know, that's our money.
1900 years.
Bishop, this man.
So this spontaneous of speech and accelerated rate of speech and accelerated rate of thought starts to make you suspicious of a manic episode, because you can get mania with psychosis, and be really important to know how much he's sleeping at night, because he's very distractible and disorganized. At this point, in the last 2 minutes, I wouldn't have been able to tell whether this is a manic episode with psychosis or a psychotic episode, because he's speaking spontaneously, quickly. There's flight of ideas. There's accelerated rate of thinking. So yeah, I would keep a close look on his mood. If you have schizophrenia and a mood disorder, it kind of depends when you get mood episodes and psychotic episodes, but let's just keep this simple. Then that illness is called schizoaffective disorder, which you might have heard about.
Hey, mister, I like that guy. Mister, suck my story, Chichi. Hey, suck me out and cop. Where?
What are you saying there?
Man's a politician. He knows everything in my
Who's
head.
the politician?
So it's getting to the point of word salad here, isn't it? So word salad is the most severe form of thought disorder where words and sentence structure is out the window. The neurons, the thought patterns are so disorganized that sentence structure is gone, and that you've just got sounds, basically, or independent words that don't actually form or structure a sentence. So that's called word salad. And he's getting pockets of it. So he's very thought disordered.
There's no politician there.
Oh, yeah. Looks work, yeah.
There's no
I
politician.
had a job. Which was I got on?
There's no politician there.
Sure, it's a politician man. Yeah, star man, $10,000. Is that it? Hey, this guy. Kick him off.
Well, you speak English, huh?
English? I have English.
You can speak English, don't you?
Yeah, I have Jewish have English.
Can you speak French?
French? No, a little bit.
A little bit?
Did I go to England, Dr. England? Go to England.
You want to go to England?
Yeah, go
What
to see
for?
American.
To go to see the Americans in
Yeah,
England?
American City, England.
American city in England?
Yeah. Why not? That's $1. This is Americana.
Where's the dollar?
Yeah, right over here.
There's no dollar there?
Sure, dollar. Sailor, extra $1.
What is that?
What is that, sailor? No.
There's
So when someone's hard to interrupt and they're speaking very rapidly, that's called pressured speech. He's getting pretty difficult to interrupt, but is still slightly interruptible. But this isn't kind of making logical sense what he's saying.
dollar.
Yeah. That's not on me, man.
Where's the dollar?
Yeah, no, check it. Yeah.
What is this?
That's it. A man died in the line.
What is it?
A man killed the guy in the street.
A man killed a guy in the street.
So it's just so, probably fair to say, impossible. It's just so hard to mentalize, to imagine what that experience of that patient is, for his mind to be jumping so quickly and to be so kind of thought disordered. And that must be a pretty, he seems pretty calm, but it certainly can be a very terrifying experience. There are different kinds of anxieties with different terms, and the common anxiety that is spoken about when we're thinking psychodynamics, like generalized anxiety disorder, it's usually thought of like a serotonergic separation anxiety, and it's usually related to attachment figures and how ones relate to others and fitting in, and those are the kind of anxiety disorders, and relates to, I guess, developmental issues after the age of, let's say, 1.5. But before that, and so there's a kind of psychotic anxiety, and that's called annihilation anxiety. And this is the dopaminergic anxiety. This is an anxiety of not knowing what is real, what is not real, and the anxiety around fragmentation. Some psychoanalysts calls it nameless dread, just really horrific, catastrophic annihilation fear. And that's the anxiety you get in psychosis, which must just be terrible. So that was really fascinating footage and a very challenging review. I hope that, it's really important when you're managing someone with these symptoms to get collateral history. So talking to the GP, family, next of kin, parents, whoever you can, just get some other sources of information about the patient, because obviously you need more than one perspective when making plans for someone like that. Clozapine, which was invited, I think it came out in the late 50s, it was taken back in the 70s and then came back out in the 90s. So something like that. Clozapine, is a very effective antipsychotic. It would have been really interesting and maybe effective for him to try something like that. But again, we can't make comments around his treatment because we didn't discuss it. So yeah, anyway, fascinating footage. I'm not sure what the course of his life took after that, unfortunately. And these days, someone like that might live in a supported independent living accommodation with 24/7 carers kind of thing, and hopefully would be trialing some really effective antipsychotics to get some quality of life, and then get involved in some psychosocial activities like group activities, art therapy, music therapy, those kind of things, and trying to stay connected with family and that sort of thing. So, you can have meaningful lives even with severe illness. But it's about multidisciplinary input and comprehensive, holistic plans. Oh gosh, that was a lot of talking by me. That's a very long video, sorry about that. But I hope that video was interesting for you guys. Very keen to see the comments to this video if you guys noticed anything I missed, if you guys disagreed with any of my interpretations, if you guys have your own reflections, just put it in the comments below. I love reading them. And other than that, I wish you all just a beautiful day full of love and connection, and I'll see you all in the next video. All right, bye for now.